Perforators are interconnecting veins between the deep and superficial venous system above the muscular fascia, generally detectable in case of overload of a venous path. They differ from the venous collectors, which on the contrary are normally detectable and represent the system of interconnection of the abdominal and lower limbs vein to the venous pelvic unit. Perforators represent an emergency defensive system activated by an increase in transmural pressure, due for example to stenosis or obstruction of a venous segment or retrograde flow with overload of a venous district. Progenic from drugs or collapse of arterial resistances in an arteriovenous fistula, preferential flow resulting from the angle of insertion of a perforator into a deep vein, functional stenosis from tendon lamination or postural clamps, congenital absence of outflow pathways of malformative origin, muscular activity with increased arterial flow and consequent overloading of the venous pathways. Of course, the number of perforators described by anatomists is higher than the number of echo-detectable perforators, which represent those that are clinically significant ones. Perforators can be classified in different ways according to their macroscopic appearance, their anatomical location, histoarchitecture, and site of confluence in the veins. We distinguish linear straight appearance of a perforator, upward as well as downward branched perforator, perforator that direct have a confluence into a straight N1 main collector, generally the superficial femoral vein, or confluence into a collateral of a main N1 collector, or confluence into an arch of a main N1 collector as happen in posterior tibial veins. The knowledge of the anatomical type of perforator certainly affects therapeutic strategies, with the aim of reducing recurrences or postoperatory complications. In fact, the disconnection of a branch perforator leaving a branch of the perforator creates a recurrence. The disconnection of a linear perforator without subfascial washing collaterals can create a thrombosis of the residual perforator stump or even an extensive deep vein thrombosis. In 2001, an international interdisciplinary committee was designed to refine terminology in order to find a common language and exchange useful information for therapy. The document presented in 2001 was developed in Rome in 2004. The document proposed in 2005 also included a topographical description of perforator veins. In Kajati's 2005 consensus, as well as in the vein glossary proposed by Perrin, Eklof and Maleti, there was no mention of the hemodynamics of perforators, but only a precise description of topographical anatomy to cover up the lack of culture of venous hemodynamics. Unfortunately, this classification created to standardize knowledge and improve therapy are not useful for decision-making on therapeutic strategy. Also, a topographical and functional description exists, and we distinguish two typologies of perforator: direct perforators from the surface to an intramuscular vein, the main N1 collectors, and indirect perforators from the surface into an intramuscular vein. Also, different anatomical types exist according to the histoarchitecture and exactly considering the different muscle representation for different pressure stress and pressure work. This is an example of a cockatoo perforator. It's a Desmond's mouth muscle staining techniques, and you can see a well-represented muscular layer. Perforator veins are a huge problem in terms of knowledge, diagnostic evaluation, and therapeutic strategy. Normally, the doppler reports in Italy read long raised venous vein reflux and incontinent perforators of the leg. But how can one define the function of a perforator without assessing its flow? To define all visible perforators as incontinent is to distort reality. Perforating veins are veins that physiologically drain the superficial venous drainage flow into the deep when the pressure gradient is favorable, so when physiologically the deep venous pressure is lower than the superficial. In addition, the closure of their valves prevents reflux when the gradient is reversed. The pressure gradient is physiologically reversed during the systole of the muscle pumps and thoraco-abdominal pump, coughing, defecation effort, Valsalva maneuver. It's reversed pathologically at rest as during pump systole when the deep vein pressure is increased by a permanent obstacle to deep flow, increased runoff resistances and consequent increase of the residual pressure. A reflux always manifests the valve incontinence of the perforator, therefore a pathology. But this valvular pathology not always creates pathogenic conditions affecting the venous function, loss of drainage or preload of the right heart. Hemodynamic maneuvers are necessary to check the flow in perforator veins. Squeezing alone is not sufficient to check correctly a perforator vein as well as a venous path. The flow in a perforator vein must be checked at rest and in the systolic and diastolic phase of the pumps. The hemodynamic tests work by creating a differential pressure gradient. The gravitational tests are able to reduce the pressure in the veins, and the Parana maneuver is undoubtedly better than squeezing. Parana can highlight an open Vicario shunt during systole, and both can detect a reflux during diastole. The Valsalva maneuver increases runoff resistances and so the deep venous pressure, highlighting the existence of a closed shunt and of an incompetence of a perforator anywhere in the lower limbs. Systolic and diastolic occurrences must be described as well as the flow at rest. Ecoduplex is necessary for the evaluation of a superficial as well as deep venous path. Ecoduplex check looks for escape points and re-entry points to identify a venous shunt preparing the cartographic report. But ecoduplex evaluation alone may not be sufficient. The ambulatory non-invasive measurement of deep vein pressure may be necessary. The deep vein pressure can be checked with a sphygmomanometer in a supine patient, perfectly horizontal at rest on both sides, but also after muscle activation to increase the flow volume to highlight a runoff problem. The proposal of a non-invasive method to measure the deep venous pressure using the continuous wave Doppler was made by Professor Bartoli in 1983. I suggest you read the papers he published reported in this slide. Bartolo proposed the venous pressure measurement in patient standing. Recently, Professor Franceschi differently proposed to check the venous pressure in supine and perfect horizontal position patients to eliminate the hydrostatic pressure interference, realizing only the real value of deep pressure thanks to the residual pressure. The hemodynamic cartographic report is fundamental to prepare the therapeutic strategy. For this reason, it's necessary to understand if a perforator represents an escape or a re-entry point, as encoded by the Shiva strategy. The papers here reported certify the value of the Shiva strategy, respect all the destroying methods, endovascular ablation included. A reflux upstream flow in a perforator during muscle pump systole caused by manual compression of the calf or Parana maneuver is always expression of a pathology of the perforator vein. However, it may not be pathogenic in the absence of a deep obstruction, but only related to the physiological inversion of the pressure gradient that diverts part of the deep systolic flow via the superficial network, but maintaining the normal direction to return downstream in the deep network and continue towards the right heart. Otherwise, the systolic reflux in the perforator vein during muscle pump contraction is pathological when it compensates an obstacle in the deep network. Nevertheless, this perforator vein must be spared because compensatory to the transmural pressure increase. It's a defensive perforator vein. The systolic reflux of a perforator during the Valsalva maneuver is always pathological and pathogenic because it translates a reflux that continues in an inverted direction into the superficial network. The systolic diverted flow continues in a retrograde superficial venous path until it reaches a re-entry perforator, thanks to the diastolic favorable pressure gradient, diastolic pump aspiration. Valsalva maneuver is mandatory in every anatomical area of the lower limbs as well as inguinocrural and perineal area. A perforator reflux activated by the muscle pump diastole, associated or not with the deep reflux, is always pathological and also pathogenic because it causes a flow contrary to the direction of tissue drainage and generates an overload of flow and venous pressure in the district. The transmural pressure increases and an impairment of the venous function may occur. But also biphasic perforators exist. A muscular systolic reflux N1 and 2 or N1 and 3 followed by a prevalent diastolic downstream flow N2 and 1 and 3 and 1 must be considered non-pathogenic without pathological value in the absence of a deep obstacle and with compensatory value in the presence of a deep obstacle. Even a biphasic perforator may represent a re-entry point. And so, what about the diameter of a perforator? Is the geometric parameter widely considered in scientific papers to define a pathogenic perforator? Is the diameter really suitable to help us in the therapeutic strategy? You can see in this ecoduplex photo a large diameter, 5.4 mm, direct continent paratibial perforator of the upper third of the leg. Paranas showed a systolic and diastolic inward flow. Despite the large diameter, this perforator is a perfect re-entry point. The diameter is the expression of the work of the perforator as for all venous collectors, but doesn't tell anything about the direction of the flow, and so about the competence or not of the perforator. The so-called re-entry perforators are often dilated by the excess pressure and flow rate of the N2 and 3 overloaded by one or more escape points. We must respect re-entry perforators as they work to reduce the transmural pressure. They are defensive perforators. For these reasons, the flow of a perforator should be defined at rest and systole and diastole of both the Valsalva and Paraná maneuver. Squeezing alone in a patient standing or sitting is not sufficient. Take-home messages. Perforator's flow must be checked at rest and also during systole and diastole of gravitational test as well as the Valsalva maneuver. Systolic Valsalva reflux is always pathogenic. Perforator's reflux during the diastolic phase of gravitational test is pathogenic. The systolic gravitational reflux alone, without N1 obstacle, is not pathogenic. Biphasic perforators are not pathogenic if the diastolic inward flow prevails over the systolic reflex. Diameter is not a suitable parameter to identify pathogenic perforators. Squeezing alone is not sufficient to properly check a perforator vein. Deep venous pressure measurement, both sides, at rest and after muscle activation, is necessary if a paranasystolic or systodiastolic reflux is detected in a perforator vein. Checking the flow in the perforator in the upper third of the leg with the swinging maneuver. Systolic and diastolic inward flow. It's a competent, direct perforator vein. Another example of competent direct perforator vein. An inward flow is clearly detectable during the swinging maneuver. Large diameter perforator in the lower third of the leg. Short systolic outflow but prevalent diastolic inward flow. It's a biphasic perforator that, despite the large diameter, is useful as a re-entry point. Direct competent perforator vein of the calf. Systolic reflux in a perforating vein upstream of the calf muscle pump is pathological but not pathogenic if followed by a prevailing diastolic inward flow or in the presence of an N3 and 2 and 1 re-entry downstream in the respect of the normal direction of venous flow. And so this perforator can be considered a re-entry point. Bone perforator vein in the leg. It looks like a malformation. Squeezing diastolic reflux. It's an upward branched perforator vein. Clearly detectable alteration of the bone profile of the tibia. Main branch of the perforator. Second smaller branch of the perforator. The Valsalva maneuver is essential for the hemodynamic assessment of any perforating vein if gravitational tests show any pathological hemodynamic pattern. The Valsalva maneuver is particularly useful in the assessment of bone perforators. Systolic Valsalva reflux. Incompetent cockatoo perforator vein. Reflux is fed by blood from the posterior tibial vein. It's an incompetent direct perforator vein. Reflux is activated during systole and diastole of the Parana maneuver and the systole of the Valsalva maneuver. This prolonged diastolic reflux is a consequence of the effectiveness of the Parana maneuver in emptying the calf veins, creating an excellent differential pressure gradient that feeds the diastolic reflux from the perforating vein. Checking first the perforator with the oscillation maneuver, with the systolic and diastolic phase. Blocking with elastic tourniquet the leg reentries helps in assessing the behavior of the perforators in the dye. An example of direct dye-competent perforator vein. The first check is done with the squeezing and the Parana maneuver. Systolic and diastolic events are evaluated. The oscillation diastolic inward flow is clearly detectable. And so is the systolic Valsalva inward flow. This perforator is a perfect re-entry point. Incompetent direct perforator of the middle third of the dye. N1 and 2 reflux during the systole of the Valsalva maneuver and during the diastole of the oscillation and the Parana maneuvers. Oscillation diastole. Prolonged diastolic reflux resulting from optimal emptying of deep leg veins during systole. Competent gastrocnemius perforator. Parana maneuver. Mild systolic reflux N1 and 3, but prevalent diastolic inward flow N3 and 1. Incompetent gastrocnemius perforator vein.